Welcome back, and thank you so much for staying with us. Now, in this particular segment, we're looking at understanding infertility. Now, in studio, we do have with us Dr. Professor Koigi Kamau. He's right here with us. He is a past chairman from the Obstetrics and Gynecology Department of the University of Nairobi. Plus, he is a chairman of the Kenya Fertility Society. And we do want to welcome him into our studios today. Good to have you today.
Thank you.
Thank you for coming. And we also do have with us Honorable Mrs. Joyce Lay, Member of Parliament, Taita Taveta County. Thank you for coming in today, Mheshimiwa.
Thank you, Remy, and good morning.
Good morning. Right, so let's get straight into this matter. I do understand, first of all, Mheshimiwa, you're doing a media campaign, right?
Yes.
Explain to us further what it's all about.
Thank you very much, Remy. The media campaign is Merck. Merck is the oldest pharmaceutical company in the world. So they're the ones who have started this media campaign. They have partnered with Nairobi University or University of Nairobi, and also with the professionals who are on that field, like Professor Koigi on infertility issues. So the media campaign is going to go around like the whole country, not just in Nairobi, but we'll have to make sure that we reach out to every person on the ground, the couple that's on the ground that do not get the message does not get to reach them. And basically the campaign is dubbed More Than a Mother, for women to understand and to know that just because you don't have a child, that does not mean that you're different. It doesn't mean that you're not a woman. You are a woman, and we want to give them a chance, an opportunity to make sure that they understand the causes of fertility, so that they get to know that there are early stages that can be prevented, early stages that can be cured, and early stages that can be detected. Because most of the time when we get to talk about IVF should be the last solution. But there is early prevention. How do people get to know that 85% of infertility causes are caused by infections? Okay. So if it's by infections, which means we can create our awareness, we can educate our people to make sure that they go for early detection. They can go for checkups once in a while in case there's anything that is found that can endanger their fertility process. Then it should be cured at that stage, at that moment. And also another campaign is dubbed Infertility is a shared responsibility. The reason why we're saying it's a shared responsibility, because most of the time women are the ones who carry the burden. Women are the ones who carry the shame, the embarrassment, the sorrow. They cry. Some of them even go to an extent of committing suicide. I mean, there was a case in Rift Valley just the other day, a woman who hasn't given birth for so many years, and she was found on top of the tree, and people were saying she wants to commit suicide because it's the pain that they carry. But then the reason we're saying that it's a shared responsibility, because up to 50% of infertility cases are with men.
Yes.
Not just women. So the couple, people should start talking. Men and women should start talking about this. Right. Because in African culture, African society, once you get married, first year they start asking, where's the baby? Where's the baby? And fingers get pointed at the woman. The woman get to carry all the blame. It's because of you, that's why we're not having a baby. We've had issues and cases of women who got married, didn't have a child, year, 2, 3 years. Later on, they got divorced because they couldn't have a child. But because they don't get to talk about it as a couple, men do not come out to go also to get tested to find out, is the problem with me or is the problem with my wife? And if the problem is with the man, there are also treatments that can be administered to them. And it's something that can be cured, something that can be controlled for them to have a baby. Okay. And you'll hear stories of women who got divorced, but when they get into another marriage, they get to have a child. So which means men also need to come out so that they can also help us carry this burden. They should help us carry this pain. We've cried for a long time without their support. So it's a shared responsibility, and Merck More Than a Mother campaign.
Most definitely. I mean, when we have that understanding, we keep on talking about it all the time, that men also do, have their own issues, and without anyone trying to admit it or even going into the way of, for example, getting medical attention, you'll find that it's always going to be blamed on the woman, and it's a two-way traffic. Both That's of you true. Are involved. So, Professor, coming to your, let me say, aspect of, this whole medical bit of it, you will find that women don't have the information that they need, to be checked early. Some women. Others take it for granted. Like we were doing an interview some time back, and this lady was saying that just because she never had any sexual relations by the age of, I think it was 22 or something, she didn't feel that she needed to go get checked, to see if she was together, if everything was fine. And there's always that, idea that unless you're having sexual relations, that's when you're supposed to get your, let me say, sexual organs checked or something like that happening. So paint us a picture of how women are supposed to take care of themselves physically, and men too, not just leaving the bit to women.
Well, I think health should be emphasized for both men and women. And one of the biggest problems we have is lack of knowledge among young people that they require to be evaluated. The society also has not created a pathway for the young people to be evaluated. I don't know what a mother in the village would think if he saw the daughter coming to a gynecologist. Right? Mm-hmm. So there's a kind of a stigma about reproductive health care for young people. So one of the aspects that requires to be campaigned for is to ensure that young women in particular get access to reproductive health care.
And is that coupled with the whole stigma on sex too? Interconnected?
Yes, that's right. They are all interconnected. Remember that infertility is a sexual issue. Mm-hmm. All right? So we need to demystify the whole issue of sex, the whole issue of reproductive health care, and so on. For example, dysmenorrhea, which is painful periods. And painful periods can be due to many factors, including endometriosis, mm-hmm. that leads to infertility. Many girls just lie under the bed in schools, or they're given some tablets to take as painkillers, they miss school, and they never come to see a doctor. So we're talking about educating people, educating young children, young teenagers, so that they know that reproductive health care is available for them. This has been the ignored segment, and this is usually the investment for the society.
Mm-hmm. And that's very important that, of course, we do understand all that. Then I'll come back to you, Mishimura.
Yes.
How do you speak to a group of women who have such stigmas? Where when you say you want to go see a doctor, your mother will ask you, what have you been doing? And not that, it's something that you're supposed to do. You're supposed to go get a checkup because it's only normal. So I think we also need to understand that, there's all that happening. Yes. And, women should have it in their minds, whichever county they're in, that treatment is quite important.
Yeah, that's true, Remy. The stigma is just so wide. It's very huge in Kenya and maybe in Africa. And the only reason that we can fight that stigma is by talking. We need to start talking. The reason why I'm talking as a member of parliament is because I've gone through that experience. The reasons that Professor has given, you go through pain and you're not getting better medical attention. My tubes were blocked and they were not diagnosed early. So I went through that pain of being through the painkillers and every kind of medicine that I could have been given then by the doctor, and also all sorts of tests that also led to complications later in life. And so I had to lose my fellow moved, and then after some time complications also came up because my cervix closed up, and after a year of going through pain and heavy bleeding, and sometimes not bleeding at all for some months because it was every time it's collecting in my uterus, it had to be removed. So I had to go through hysterectomy. And that's the reason why I opted for the IVF process for me now to get a child. So you see now IVF is as the last resort and very expensive for a common, couple to afford. And the reason why we're doing this campaign is for young girls and women and men to get the education. Because without education, then they wouldn't know that there is a need even for them to go for pap smear, to go for any other checkups that, at that age. Because I remember when we did when we launched the Merck campaign, there was a young girl, I think she's not even 20, and already, she's going through complications, and I think she had to go through hysterectomy also. So imagine at the age of 20. So yes, it's a campaign that we have to keep on talking. We have to educate people. We have to make people understand that there are medical facilities within their reach, and the problems that they're facing, if they're detected at a very early stages, they can be cured. They can be cured right there where they live.
Okay. So, Professor, what other options do women have? When Shimui is saying that, they need to look at all other resorts, what are all these other resorts before considering IVF?
Well, I think you look at the causes. If you have infection as a major cause, for example, abortions may be associated with a lot of infections, and abortion is a major problem in this continent and in this country. So they don't want the pregnancy to end, but 10 years later they will want another a pregnancy because they'll get married. So one is to treat these patients immediately and effectively. This is why we talk about access to effective diagnosis and treatment. Endometriosis, I mentioned it, is an ignored subject in general, all right? And it's actually it's a burden in this country, all right? I am doing a lot of cases of endometriosis even in young people. So it needs to be diagnosed and treated. And they are advised about utilizing their reproductive potential sooner than later, yeah? So we need to prevent this. We need to educate the young people about the risks of infertility causes, like in particular infection. Yeah. So then if you do that, then the burden, because about 60% of my time in the government hospital where I teach, I use it treating infertility. All right? All right. So we end up doing the things that may not help very much, like doing tube surgeries, all right, trying to improve the tubes. Sometimes infections cause the uterus to close, literally, all right, to get adhesions, call them adhesions. Literally it's closed and you can't get pregnant. Sometimes even don't get the periods, all right. So this is it. The other one is that women should know that they should be screened for fibroids. Fibroids are very common. All right? And when you are screened for fibroids, you know the organ that's being affected is the uterus. And you know that even if they're removed today, tomorrow they will come back. And therefore, if you don't utilize that uterus, one day it might be removed before you get pregnant. So that kind of knowledge needs to permeate through this campaign so that people know and get aware. They know that the value of the uterus is reproduction.
That's true.
Yeah? All right. Many women and many men do not appreciate that fact
until way later.
Until very late. Yes.
Right. So, Mheshimiwa, let me take you back to a point when you were in Parliament and you spoke about this matter and you're very emotional about it. Do you feel there is a lack of understanding, especially on the way we view infertility, despite the fact that one may say that we're in a very exposed, let me say, community, or we are at an exposed time? Do you feel that men still don't understand it? Women also do look upon other women on that matter. What's your experience?
Yes, that's very true, Remy. There's a lot of looking down upon women, especially women who can't conceive naturally, women who can't have kids. I mean, that's why we find them hiding somewhere. They're not talking in loud voices. It's always in hushed tones. And the reason why they talk in hushed tones is because they're embarrassed. The stigma, I mean, it's it's unbearable. I remember, huge experience when I was running for office. It came up as a reminder that you cannot elect a woman who cannot give birth, a woman who doesn't know the pain of having her own child. It was just a huge reminder to a point where, like, you know what, I'm going to give up. But then you're like, I'm not going to give up because of this, because I need to have a platform to be able to tell my story, to be able to encourage other women to come out and speak out. Because when I have that platform, then they get to understand even where she is. She went through the same pain as we're doing right now. She's gone through the same tears, the same embarrassment, the same, she bear the same pain as we are. So when they hear us speaking, then they get encouraged and they start coming out from their hiding places. And that's the reason why when you saw me in Parliament, because we're trying to move the IVF bill, because IVF has been in the country for years, and maybe you're going to hear later from IVF center expert, but there's no policy. We don't have the policy. We still hold on to our traditions and culture. At this time, at this age, 2015, surely culture and tradition, yes, we can do that. But when it comes to, scientific and technology that is advancing every day in and out, then we have to catch up with technology. IVF is a technology that is there in place to help women, to give joy back to women, to help them have their own child. It's something that we should embrace. And the government, it's high time now we make sure that we have that policy into place. Mheshimiwa Millie Odhiambo has been moving that, and it's going to come up for third reading very soon at the committee stage. And we're encouraging as many Kenyans as possible to go through the bill so that we can have the amendments. Even the religious group, we encourage them to go through this bill so that they can also bring their amendments, because they have their own fears, and we can accommodate that. But this bill is the best for Kenyan couple, and also to encourage the government to make sure that they put funds in research, funds in training, because I think we have only one embryologist, or maybe we don't have at all. Professor will clarify on that. So we need to invest money in that to make sure that we train people, and also to make sure at least every level 5 hospital in our counties have an IVF clinic, infertility clinic, where women at least and men can access, that can be closer to them. Because when we bring it closer to them, that means even the cost of it is going to be affordable. Because right now it's for who can afford.
Okay.
Because every trial is money. Every trial is money. And sometimes people even go up to 14th or even 10 times. And every time you try, you have to put in money. So for normal mwananchi, that is not affordable. But if the government can take this as a burden and make sure that we have easy access to that within the county. To put up an IVF clinic, it should cost around 15 million. That's what we were told, Professor.
Yeah, it's about 10 to 15 million.
10 to 15 million. That's something that the government can afford. Not just even the national government, even the county government, if they put their funds together, they can afford for easy access of wananchi.
Okay, right. So I know we do need to release you right now, but before we do that, before we come to you, Professor, just one more question, Mheshimiwa.
Yes.
We need to understand this factor. When was your lowest moment, as a lady, who is in Parliament? As a lady who has gone through this matter, but you're trying to give your voice out to everyone else who has, speaking on behalf of women who don't even have the chance to even get the platform, to get on the platform you're on to speak about the matter.
Yes.
And how did it change your life, and how did it, chart your course on this matter?
My lowest moment was when I had the baby, and I could not legally own that baby. And yet, that's my baby. Genetically, that's my baby. So because of lack of policy, I had to go through adoption to adopt my own child. And the process took longer than usual adoption process, because moved, has us involved, and it took almost 4 years. And for me to try and explain, that's why when you saw me in Parliament, it's so emotional when you know that you have a baby already, but legally this baby does not belong to you. Anytime the surrogate mother can come in and take the baby away, and you can't do anything. You can't take her anywhere, because the law says the woman who gives birth is the mother of the baby, full stop. So the woman who gets a child through a surrogate mother is not recognized by law. The woman who gets a child maybe through adoption, you have to go through, documentation process for you to be recognized as a mother. That was my lowest moment. But then the reason why I took the longer route, it's because I wanted to walk that journey, to be able now to speak on behalf of the women that are going through the same pain, and to be able to make sure that there is law and policies that are in place to recognize women that go through such pain. And I thank Merck Pharmaceutical Company, because it has come at the right time, where stigma is so hard on women. We have to make sure that, women get considered as, you are a woman. It doesn't matter that you don't have a child or you have a child. You are a woman. God created you a woman, and that cannot change.
Most definitely. And we're happy that you could share with us your story on that matter.
You.
And I do wish you the best on that campaign.
Thank
and
you.
I do hope that many people are aware, on this particular matter, and as sober to look at it. So thank you so much for coming in, Mheshimiwa.
Thank you, Remy.
We're taking a short break. We'll be back with the professor and an IVF expert in just a bit. Stay with us.
Thank you.
Welcome back, and we're back with this discussion on infertility, understanding it. We want to know today if we do have very strong policies or not, or are there any plans to make sure that indeed, we will be getting them as a country. Now, let me introduce to you, that is Dr. Joy Noreh. She's the director, Nairobi IVF Center. Thank you for coming in, Doctor.
Welcome.
Good to have you here today.
Thank you.
All right, now before the break, I was discussing with Professor and Mheshimiwa Lay about this whole matter of infertility, right? And before you say something, I want to give Professor an opportunity to tell us about if we'll ever get to a point we can remove, culture from the whole aspect of science. Remember, there's the whole bit of being an African, and there's that argument I'm sure you've had maybe from some of your patients, Professor, where they'll ask you, but, I believe in this and this. This what you're saying, talking about is very Western. And how are you able to convince some of your patients that this is the right direction to go? Of course, we'll have to go back to the whole matter of sensitization.
Well, I think what we require most is what Merck has called a cultural shift. The problem of infertility has been feminized. The society, the families see the problem of infertility as a problem of the woman. So the woman is the first to seek for the services. And even then there's inertia. They may take several years before they make a decision that they were going to go and have checked for the infertility problem. And when they go alone. And men are unwilling in general to go to be checked, to be examined. So the problem has been left to the woman. All right? And I think our role, wherever we work, our role with the Merck, our role with the women's members of parliament, our role as a university where I work, is to ensure that this cultural shift is effective, so that men and women realize they are equal partners in reproduction, and therefore when there's a problem, all of them should be checked.
Okay. So as a director of the IVF Center, I think we need even a lot of awareness on that part. We keep on hearing IVF, but do we even know how long it has existed? For example, in Kenya, when we're speaking of administering IVF, at what point or what stage? One thing that is very clear is it's supposed to be the last resort, and also it's very expensive. But because you're the director of the center, I think you can be able to paint us that particular picture better.
The Nairobi IVF Center has existed for about 10 years now. Mm-hmm. And we had the first IVF baby in Kenya in the year 2006. That is May 8, 2006. And IVF has been practiced since then in a very active manner. Mm-hmm. The costs are quite high because medications and experts are expensive. But that can be looked into if many things can be done. One is if we get many, if we can get a price cuts, particularly on taxes, on medication and equipment, the costs may go down. Also, the experts, let's say the embryologists. Kenya does not have many embryologists. We have only, say, one, and he's not able to
handle every case.
To handle all the cases. That is Dr. Joshua Noreh. But this can be done, let us say, the universities can be empowered to train very many embryologists, because I believe the government can bring in some experts to train the embryologists at the university, say University of Nairobi, because we have all that it takes. We have the infrastructure is there. It is not very, very expensive to start an IVF center. You'll be surprised that 4 Pajeros can be enough. If they are sold, they can start an IVF center. Okay. And that's how cheap it can be.
So what we want to understand, Professor, right now are the policies. What kind of policies do we have in our country? And with someone who deals with this technical bit of it, the medical aspect, how is the state of our labs, in Kenya?
Now, well, when you talk about policy, there's something that has dragged along for a long time. All right, and we're probably now at the verge of it because the bill has to pass, so that then regulations, policies can come up, and then regulations can be derived from the policy. So at the moment, we're using other countries' policies, all right, standards from a developed world. But otherwise, we can say that we're operating in a vacuum, and it is very dangerous to operate in a vacuum. So when the bill goes through, which I believe we are, because we are involved in giving the technical aspects of that bill, we have toothpicked it in and out, all right, then we'll be able to have a regulatory framework, all right, that will be overlooked and managed through an authority. So the authority will be able to give regulations and directions on how IVF should be practiced in this country. Because for the time being, I think we're operating in a vacuum. But remember that it was important that IVF starts so that the need for regulation can arise. So it's an advantage that it started.
So the question would be, what policies are we dealing with from which year? What policies are governing our reproductive health decisions, like what Commissioner Lay was saying in terms of the mother who's given birth to the child, even if it's a surrogate mother, is the mother of the child?
I think that one we don't have, and that is the problem. That's exactly what she went through. All right, there is no policy that says that the baby is yours. And I think one of the genesis of this bill, one of the strong points, is so that a surrogate mother can be recognized as the true mother of the baby. It's a genetic mother anyway. So at the moment, there's no law that governs that. So there's no policy as such, unless you have something to say about it.
Yes, maybe you can explain to us that matter when you're administering IVF. Is there any policy like, he's mentioning, Professor?
No, there is no policy governing the IVF practice, but what the Nairobi IVF Center has been using are borrowed ideas from existing IVF centers internationally, and therefore we were dealing with that and also using our Kenyan law. We interpret it. You see, the law is just about how you interpret it. So like when you come to a fact that, like in the Public Health Act, where you say every woman has a right to reproduce, you pick that and interpret it and give the woman the privilege of getting a baby at as she desires to have. So it is, we have just been going around the interpretation of the existing law positively and what the other countries are doing, as long as we are within the practice that is legal. Also, these laws have also to be looked at actively, because there is no point of frustrating a mother, a desiring mother, especially in the area of surrogacy and donation of gametes. They feel that they are kind of frustrated, especially where the bill is indicating that they have to register these babies separately. Under reproduction, there are only three. We look at three parts: conception, carrying, and delivery. So these mothers should be given the same equal rights as those ones who are having cesarean section, because it's difficult in delivering these babies. And the ones who have had difficulty in carrying, like miscarriages and so on, they are also supported. But the one who is planning to conceive is not supported. Look at the way the insurance companies are balancing it out. The ones who are looking for a baby are not supported, and yet the ones who are already carrying and going to conceive, maybe under an operation, are quite supported. I think there is, the law is not, or rather, the system is not fair. These couples should all be supported.
Okay.
And I'm sure the health bill, when the bill comes and then the health bill comes in, it should look into all those matters.
Right.
Also, insurance companies, they put it straight in black and white. We do not finance infertility. You see, and yet it is just a disease. Look at it like someone who has diabetes, that is hormonal failure. Someone who has follicle-stimulating hormone is a hormonal failure. Both are suffering from a hormonal failure of a different type of hormone, and yet one is supported in their treatment and another one is not. I'm sure when the law is being passed, they will look into those nitty-gritty elements and see how to support these clients.
Okay. Yeah. Right. Professor, what do you have to say about that?
Well, I think what I can say is that this need for a good regulatory framework that recognizes infertility as an important public health problem. You see, we in Kenya, we have very high fertility rates, and the government appears to concentrate on reduction of fertility rates, lowering fertility rates, and therefore ignores the infertile couples. Every woman has a right to access to health. And I think infertility should be seen as a sickness, as an illness. And we think that the government should do all it can to improve the services, the infertility services in the country. Okay. The problem is the common man, like Mheshimiwa was saying. The common man and woman, all right, they don't get access to adequate, good, effective management of infertility.
So the question would be then, how many medical facilities would we need in Kenya that is wholly, in the counties, right here in Nairobi, to make sure that, whoever needs, even let me say, just a checkup, of them to, understand and know what's happening within the productive, health systems, whether a man or a woman, that can be able to be administered. Like, in some areas, they have to walk long distances to even get treatment, or even, know how they're doing. And like you said, we've spoken about this, right now, is that, the whole aspect of culture comes into play. So what does the government need to do in terms of equipping these facilities, equipping the scientists, getting more embryologists, like you've mentioned, making sure that, the more, let me say, institutions also, getting more, let me call them doctors for that matter, or gynecologists into this matter to help in, fighting, let me call it, the sickness that is infertility?
Well, we love this system of devolution, because now every hospital can have even a facility section of it. Because in every county, you can just have a department and call it a fertility center. And particularly that most hospitals have room. They just need to develop it. The only obstacle here is the specialists. And also the universities in Kenya do not train fertility, do not train their doctors on that fertility part of it, particularly the embryology part, and it is the final stage of handling it. But as we know, there is part training on fertility in the universities, but it is not as deep as it is supposed to be now, because every medical aspect of it is evolving, and particularly the IVF world is still very new. It's just less than 40 years old. So in science, that is a very new field. So if every county could have a fertility department, then we would have the what we call the filter done, and the basic treatments done at county levels, and referrals can come now to the way we refer patients to the main hospitals like Kenyatta, Moi referral. That's where now where you will find costs will go down, because some cases they are started from the cases that could have been handled at a basic level. They suffer for a long time trying to find the solution until they get to the specialists. All specialists or all hospitals should have a specialist at the peripheral level.
Okay.
That will be cheaper and faster.
Right. So, okay, I understand we have a phone call. Hello, good morning. Hello.
Hello, how are you?
I'm very much okay. What's your name with your question or comment?
I'm Rose from Buburu. I'm calling to ask.
Yes.
I did the permanent with fertility, whatever, and then I also nikaenda nikatolewa, and then nilipotolewa bado fertility yangu haijarudi. So I was asking, what do you do, because nilikuwa nimefanyiwa ile permanent? How do you call it, the permanent family planning method?
Okay, right. Okay, then thank you very much for that. I don't know if you got her question clearly. Oh, okay. One of you can answer.
Yeah, she is asking. She had, if I can rephrase it, that she had a permanent. She was done bilateral tubal ligation. That is how we call it in obstetrics, and therefore she cannot therefore conceive. So how can she be helped? You don't need a tube to get pregnant. That is a straight candidate for IVF, because you can bypass the tube and get the eggs, fertilize them with the husband's sperm, and put back within 72 hours back into her uterus.
Oh, okay.
And that's it.
Right.
Yeah.
And I think, owing to that, just before, we had the phone call, I was to ask this professor, what are those telltale signs that men and women should look out for, as red signals when it comes to there's something wrong with their, productive health?
Well, I suppose by the productive health in this context, you mean achieving fertility or not achieving fertility.
Yes, like,
yes.
Any sign, of a woman, maybe if you have discharge, maybe if, a man feels uncomfortable in his productive organ in any way, like what should they look out for?
No, I think...
Okay, before you answer that, we have another phone call. Hello, good morning.
Hello?
Good morning.
Morning.
Yes, good morning. What's your name?
I'm Noreh. Thank you for the program I'm watching.
You're very welcome.
Yeah?
You're very welcome. You can go ahead.
I'm watching the program.
Yes.
I want to be ready for it.
You want to?
Nataka kushukuru.
Ndio. Utakuuliza
Then I
swali.
want to ask, nauliza, can you be kindly do the same program on an evening time?
I beg your pardon? Tafadhali rudia.
Nauliza kama kuna uwezekano wa kurudia hiyo program wakati wa jioni.
Kuirudia.
Alafu nauliza kwa experts wao wako kwa studio. The question about self-determination ya mtoto. Alafu another question.
Another question?
Hello?
Yes?
Swali lingine. Nimeshauliza wewe ya self-determination ya mtoto. Alafu the question of fibroids. Mwenye ako na fibroids.
Ndio.
Zingine zina breed. Na consumption.
Okay.
This is somebody mwenye ako miaka 40 kwa sasa.
Okay. Sawa, tunashukuru. Asante sana. Thank you. Maybe Professor, you can answer, our view with those questions.
I got about fibroids.
I got the other one.
Okay, so maybe you can answer the fibroids one.
So fibroids are growths that arise in the uterus, and they can affect fertility, either by blocking the fallopian tubes or the fact that they're inside the uterus, and therefore the fertilized egg cannot implant. All right. Now, so the best thing is to remove the fibroids. And when the fibroids are removed, then you check whether the tubes are closed or opened. If they're opened, then you can give a chance to get pregnant naturally. If that is not possible, then you go for IVF.
Okay, then. Right, you got the other questions he was asking?
Yeah, he was asking about sex selection. Yes, sex selection can be done, and you can do it for various reasons. At Nairobi IVF Center, we can do sex selection. We started this year to do sex selection, and we are doing it on medical grounds, not just to come and say, oh, I have 10 girls, I want a son, or I have 7 sons, I want a daughter. No. There are certain conditions whereby you need a specific gender so that you bypass the disease factor. Like, let's say, like in sickle cell anemia, or in hemophilia, you may need to do sex selection. Also, under sex selection capacity, you may also be having a problem with the DNA of the parents. So we can do embryo selection, whereby you can pick the right embryo that has bypassed that disease factor. So we can do it at the Nairobi IVF Center. We can do sex selection, and we can do DNA or genetic assessment.
Sawa.
Yes.
So, Professor had asked you before about, the red signals one has to look out for.
Well, the signals then are going to be those signals that may lead to infertility. So one is discharge that is abnormal, either different color or smelling, and if it is associated with pain, like low abdominal pain, for the woman, low abdominal pain before menstruation, usually there's a signal that there's a disease in the pelvis that can affect both the ovaries and the fallopian tubes, like I said, endometriosis or like pelvic inflammatory disease. In man, urethral discharge is important, testicular pain, all right? This could mean that there's infection in the urethra, in the vas, and in the testes. So those are indicators that the reproductive system is at risk of malfunction.
Okay.
if attention is not given promptly.
Or at the right time.
Yes.
Okay. Right, so we do have another phone call. Hello, good morning. Hello.
Hello.
Good morning.
Morning.
What's your name with your question or comment?
Jane from Laikipia.
Yes, Jane.
Yeah.
Talk to us. We can hear you.
Yeah, hello.
Yes, we can hear you. What's your question or comment?
Mimi naitwa Jane kutoka Laikipia.
Ndio.
Nilikuwa na swali nauliza. Nimekuwa nikitumia coil for the last 13 years.
Okay.
Na hii coil nimekuwa nikienda pap here. Regularly. But for last year niliitoa.
Okay.
Na nimekuwa nikijaribu kupata mtoto. Lakini sijafanikiwa.
Okay. Kwa muda gani umejaribu kupata mtoto? How long have you taken?
It's almost 1 year because nilitoa last year June.
Ulitoa 1 year ago?
Yeah.
Okay. Sawa. Let's see what our experts have to say. Yes, okay. Professor or doctor?
So the coil or intrauterine contraceptive device, commonly called as IUCD, is a good contraceptive method. The coil does not cause infertility. Okay. However, if you get infection with it, then it may cause severe infection and may lead to infertility. So it's not the coil causing, it is the infertility. It is the infection. Now, remember that whether you have a coil or not, if you stay for a long time, more than a year, without getting a baby, then you need to be investigated. And the advice that I will give is that she is not getting pregnant after 1 year. If you're exposed for 1 year and beyond, then we say you have infertility.
Okay, and let's get this clear also. In her case, she's been trying for a baby, right? So, and we've had another, other scenarios where you'll find some couples who have not been, trying for a baby. They've not been, having sex rather, but the lady is not using contraceptives. So, how do you base the two scenarios? Are they one or the same thing, or are they different?
I think exposure is important. In other words, exposure is regular coitus, regular sex, because coitus. That is a must before you make a diagnosis of infertility. Yeah. And here the investigation cannot be assumed that it has to be on the woman. It has to be on couples. Because once fertile, it doesn't mean that you always remain fertile. Situations do change, both in man and woman.
Okay, and then what do we need to understand about contraceptives also? Because I've had many cases where you get an infection because of maybe using a contraceptive for too long. But as Professor, you're saying, it's not about the contraceptive; it's about the infection. So then, how how can one also be making sure a woman for that matter, she's also be getting a lot of let me say checkups for that matter and the like.
Basically, a woman should have a checkup every year. But we confuse contraception and then infertility, missing or rather delayed delayed conception, then infertility, and then contraception. So we confuse the three factors until we confuse the clients. Now I'll go slowly. One, when a woman starts to use contraceptives, they are indicating that at that time they don't want to conceive, they don't want to get pregnant. But you see, there are times when you want to get pregnant after using the contraceptives, or rather let us use the word family planning for easy understanding. Then that is when you realize that no, my body is now not conceiving a baby after using. So many times contraceptives have been blamed to be the cause of the infertility. It is not so. There are times when the body has had a turnaround within it. For example, if you use, as Professor has said, a coil, and then this coil has got infection. Not that your husband or the husband has come with some sexually transmitted disease. No, there are times when there is just general infection of the in the vaginal tract. So you find that infection, the coil has moved with it until the pus forms within the fallopian tubes, and it blocks the tubes. You find during healing time, the fallopian tubes are blocked. So that one already is blocked tubes. Therefore, the woman cannot now conceive. The egg cannot come from the ovaries through into to be fertilized by the sperm. So now there is that. Secondly, there are those ones who use the injection, and frequent use. You see, those are hormones to stop you from conceiving. Let me put it in the simplest form. That they mimic a pregnancy. So the hormones, let me put in the simplest manner, is they make the body feel that no, you don't need to get pregnant, or so in that sense, the woman will not get pregnant, and in due course the body gets used to that hormone, and therefore she gets into an off balance. When she wants to get pregnant, the time she wants to get pregnant, she will not be able to conceive.
Okay.
And then you'll find that it is not the hormone that has caused her to conceive. She has developed hormonal imbalance.
So just hold on to that thought. We have a phone call.
Yep.
Hello, good morning.
Morning, how are you?
I'm very much okay. Where are you calling us from?
I'm calling from Kilifi County.
Okay, talk to us. Your name is?
Mapenzi.
Okay, Mapenzi, talk to us.
Okay, my question is,
Yes.
first of all, I'd like to appreciate whatever it is that you're doing. I'm really learning a lot. Yeah.
You're welcome. You're welcome.
And my question is, last year I was done an operation to remove a cyst from my stomach, an ovarian cyst.
Okay.
Yeah. So and after that I was told that I can't conceive maybe up to after 3 years. Now, from last year up to now, I only got my pills twice, and it was not the normal one. I think just for a day, and it was over.
Okay.
So my question is, will it really be possible for me to again get a kid? Because the doctor told me that the operation was quite intensive, and is it possible that I can get a kid again? Or
okay, you already have a child, yes? You already have a child, yes?
Yeah, I have one child, and the child is cerebral palsy.
Oh, okay. Right.
Yeah, so now I like really need a kid, but it's like I don't know if it's possible because I don't see my kids again.
How old is your child? How old is your child?
6 years.
6 years old. Okay then, Professor, I think you can help Mapenzi.
Yes, Mapenzi, that's an important question. Now, I want to state that removal of a cyst does not make you infertile. A removal of a cyst actually improves fertility. If you want to do IVF and you have a cyst, we actually remove the cyst first. All right? So, removal of the cyst improves fertility. It doesn't matter what type of a cyst. So what we're saying, there could be a concurrent problem, something else that is happening in Mapenzi. One of the things that she requires to do is to go straight into investigations. For example, do an ultrasound and look at the ovaries and evaluate both the structure and the functioning of the ovary, so that we may not be able to blame the tube. Now, the actual operation that was done, maybe she may not be knowing it 100%. Is it the ovary that was removed? Or is it part of the ovary that was removed? Or was it the cyst? The cyst is just removed. We call it enucleated, removed from the ovary, and the ovary is left intact. So what am I saying? That she requires a re-evaluation to determine the state of her ovaries. All right? Yeah.
Okay. Well,
Also, just also to add on what Professor has said, Mapenzi needs also to go for a hormonal check, because she has indicated that this year she has had her periods twice only. Therefore, she could be dwindling into as a condition where her menopause is peeping, or rather,
it's had very early.
Yeah, and the age of menopause is not exactly known, because some people get into menopause as early as even 25 years, and as so age of menopause is not that when you are 50 is when you are in menopause. No, you can get those hormones reserved as early as even 28 years. Okay. So she should go for hormonal check, and particularly the anti-malarial hormone will be checked, and many other hormonal tests. Her husband should also be checked, because it is not that when a woman stops conceiving after having delivered once, it's now her problem. Her husband's sperm should be checked. Sperm can stop functioning anytime. Okay. Just the way the woman can, her fertility can stop anytime. For a man, sperms can reduce anytime. Okay. So all the time we encourage the Kenyans or the people concerned or couples to keep checking their fertility rates. Yeah.
Right, that is so interesting. Okay, before we take a short break, we have a phone call. Hello, good morning.
Not getting.
Good morning to you.
Yes, what's your name with your question or comment?
My name is Caroline. I'm calling from Busia.
Okay, Caroline.
Okay, I also have tried to get pregnant, but to no avail.
Okay.
I stopped using family planning 6 years ago.
Okay.
But I have tried severally to get pregnant, and I can't. I don't know what my problem is.
Have you sought medical attention?
I have tried, but they have said that I am still fertile, and I can still get a child, but I haven't.
And have you gone with your husband? Oh, okay. Right after the break, our experts will respond to you, Caroline. We'll be back in a bit. Stay with us. Welcome back. Thank you so much for staying with us. Now, before the break, we had a call from a lady, Caroline from Busia, who was saying that, she's been trying to get a child for 6 years now, and to no avail. So she said she's gone for treatment, but, the doctors tell her she's still fertile. But the question is, has she, gone with her husband? That was before, I think maybe her credit got over and the like. So I think, Caroline, if you can call us again and give us all those details, I think our experts can help you better. But, Dr. maybe according to you, what do you think the problem is? 6 years? Because there's always that misconception, like you've mentioned, before even Caroline called, about what we deem contraceptives to be. Because she said she's been off them for 6 years, but to no avail, she's not getting pregnant. What is the problem?
Infertility can be caused by many reasons, and what she's describing is what we call medically secondary infertility, because she has delivered before, and hormonal therapy, because she has been on hormones, to do family planning. That is what we call it at a basic level. Family planning or contraceptives is a hormonal therapy, especially if she was using the injection. And therefore, she needs to be reassessed so that they know, is she already in a hormonal imbalance, and therefore can her hormones be balanced? That is a case where Professor will explain also. There can be hormonal imbalance in her, and she needs to be returned back to scale. Secondly, she could have also developed what we call a premature ovarian failure, which she may not know. She needs also to be assessed. Her husband's sperm may also be low. He may be functional, but he is producing a few sperms, because for a normal baby, natural standard, you need 40 million sperms to make one baby. So sometimes some people, if you produce 20 million, those are still million enough, but they cannot produce a baby naturally. You may need to do insemination, or you may need to do IVF. So it depends on very many factors. So she needs to visit a gynecologist, and in Busia we have gynecologists who will do basic assessments. As she has said, she has been assessed. She can still go further and visit an IVF center. We have many of them in Nairobi.
Okay.
Yeah.
Right. So, Professor, I think you can, continue with, the questions she threw at you. That was of the hormones, I believe.
Yeah.
The hormone part, yes.
Yeah, I want first of all to say that family planning methods do not cause infertility. I think we should not get out of this place with that notion. All right? You can only be developing infertility because other factors are coming in. Now, in terms of hormones functions, there are many things that affect hormones. You can have age as a factor. Fertility is very much dependent on age. The most fertile age is between 24 and 32 years of age. After that, fertility decreases. By 35, it is really down. By 40 years of age, it is very down. All right? By the time you reach 45, it's virtually non-existent. You only get occasional woman getting pregnant here and there.
So let me ask you this, because I mean it's quite interesting. You'll find in some Western countries some ladies getting married very late, at 40 or 41, 42, right? And that's when you'll find someone getting their first child. So is it that they have different facilities, or is there something we're not understanding here?
No, it's the same thing. They have difficulties in conceiving. You say you're lucky to see those who have conceived. For each one of them, there are very many others who are not conceiving. And if you go to the Western world, because of this age issue, fertility clinics are very busy. All right, so IVF, many more babies are born from IVF. All right, the populations may not be very high, but the clinics are very busy. Well, this is the contribution is mainly due to the age factor, getting married late. All right. That's right.
Okay. So, right. Just before you continue, Professor, we have a phone call. Hello, good morning.
Morning. Hi, how are you?
I'm very much okay. What's your name with your question or comment?
Okay, I have a question. I'm just 25 years.
Okay.
And I've been trying to get pregnant. The only process that, the only unit that I used once was a coil.
I beg your pardon?
I used a coil once.
Okay.
But now I removed it after 3 years. Will that make me not be getting pregnant?
Okay, right. Thank you for that question, Professor.
Yeah.
So then it's the coil.
Okay, we have another call. Hello, good morning. Hello?
Hello?
Yes, good morning.
Morning.
What's your name with your question or comment?
Hello?
We can hear you. What's your name with your question or comment?
Okay, I'm Teresa. I'm asking about family planning, whether it can affect somebody.
Okay, that's what even Professor was actually answering. So just keep listening. He'll be addressing that more. And, Dr. Hello, good morning. Hello?
Morning. Hello?
Yes, good morning.
Good morning.
Okay, what's your name with your question or comment?
Okay, my name is Tabby.
Yes, Tabby.
Niko na katoto kako na 6 years. And then after that, nikapata ectopic akiwa 1.5.
Akapata nini?
Ikakuwa na ectopic.
Oh, okay.
Then later on, after katukangu amefikisha 6 years, nimejaribu kupata katoto kingine.
Okay.
So tumekosa kabisa. So nauliza daktari, shida inaweza kuwa ni nini?
Haya, sawa. Tunashukuru. Asante sana. Okay, fine. Right, so I think you'll answer the first call of the coil, yes? And Daktari, you can answer, Tabi's question on the topic, is it pregnancy? Topic pregnancy, yes.
Okay. Well, let me say that I want to repeat that family planning methods do not cause infertility. So that association is not true. Other factors come in, and they can come in with or without infertility. The coil works by just its presence in the uterus. When it is placed in the uterus, it causes what we call sterile inflammation that prevents either sperms passing through or the implantation, if they happen to pass through, of fertilized egg. It may have other mechanisms that affect the transport system within the reproductive system of a woman, but it will not cause infertility once you remove it out. So it does not cause infertility, and what she needs, I think she was called Tabila, what she needs to do is to go and get investigated to find out the real cause why she's not getting pregnant.
Okay, right. And I think you can answer the next question, Daktari, of the lady of the ectopic pregnancy.
Yeah, thank you so much. Ectopic pregnancy, what happens is when a lady conceives, and that conception or that, we call it fetus, is conceived within the fallopian tube. Then you see the fallopian tube has a capacity that it can expand to or stretch into. So it cannot stretch up as much as a uterus can, and therefore that is why it is at that level that it has to be removed. In fact, the tube bursts. I'll try to say in a simple language as possible for basic understanding. So the tube, being narrow, will burst, and it can bleed, and it can bleed, and so many things can happen. But since this lady, it was diagnosed that she had ectopic pregnancy, and the assumption is that the pregnancy was removed, whether it burst or before it burst, during healing, chances are, or during the surgery, chances are that they closed that tube so that it does not have to cause another ectopic, because it is now going not to be straight. It has already been stretched to a limit that it may not be straight back to shape. So it was either during the healing, it healed with the scars or whatever happened there. Therefore, it basically is, it cannot propel an egg to come to the uterus.
Okay.
And that is how basic it is. Therefore, she cannot, that tube may not be used.
And I think we also need to look at the wrong diagnosis, just in case, because the awareness, if I don't have awareness about something and I'm getting treatment for it, maybe the full awareness, my own knowledge, I've done some research, and maybe the doctor has done his own things, when it comes to tubes and stuff, and I think we can also have cases of wrong diagnosis.
No, the thing is...
Let me say that the treatment of ectopic pregnancy, the standard treatment of a ruptured ectopic pregnancy is the removal of that fallopian tube.
The removal?
Yes. And what this lady needs to know, or should have known, is whether the other tube looked normal. Because remember, you have two tubes. You not one tube to get pregnant. So is the other tube all right? If the cause of the ectopic pregnancy could also be the cause of the blockage of the other tube, because it means the tube was not normal. That's why the pregnancy did not pass through. Okay. And I think, again, you come back to the issue, establish the truth. Go and get tested about the other tube. Then you know the cause of the infertility. Well, notwithstanding that the man must also be involved.
Okay. Also, under the Client Bill of Rights, which is now coming up in Kenya, the right to know. Sometimes we assume that clinically that the patient knows. So I think as the doctors are trying their best to inform the patients also should be able to ask as much questions about what actually happened, not to assume that the doctor is going to explain
the miracle
it.
Worker, yeah.
It is also everybody's responsibility, just like Merck is saying. It is everybody's responsibility to propel the fertility factor, and therefore the patient has the right to be told, and also the patient should also ask about what happened to them.
Exactly.
Yes.
I mean, I do agree that information is very key and powerful. Hello, good morning. Hello.
Hello.
Yes, good morning.
Yes, good morning.
What's your name?
I'm Beth.
I beg your pardon?
I'm calling from Nalok.
Okay, Beth, talk to us. What's your question or comment?
Yes?
What's your question or comment today?
Okay, it's a question.
Okay.
Yes, there is a time I went through a surgery, that is 205. I had a tube blockage, bilateral tube blockage.
Okay.
Then after operation, I was told it was through the TB. They found TB cells in my tube. And so since then, I have not gotten, now it's 12 years.
And those cells have?
I just need help. Okay, I need the help. I was told I should go that IVF, whatever. So I just need the help. I am 12 years now. I got TB cells after operation in Kenyatta National Hospital. I was told I have the TB cells in my tube, which has blocked my tube.
Okay, we hear you. We hear you. Okay, I hope you got the question. Just keep it in mind.
Tuberculosis,
yes. Keep it in mind. We have another phone call right now, then you'll be able to answer that. Hello, good morning. Hello?
Good morning. Hello?
Yes, good morning. What's your name?
I'm Judy.
Yes, Judy. What's your question or comment?
Okay, here comes my question, please. Now, I've been having very heavy bleedings.
Okay.
And they come out with some things like meat, nyama hivi. I've never aborted.
Okay.
And they are very smelly. Then I've been going to hospitals and I've been always told that I've got hormonal imbalance.
Okay.
And right now we've been with my husband for around 8 months. I've been trying out for a baby. And the results are not coming out positive. Then I'm like, now I've started being worried, and I've tried all the best means to go seek for medication, but the results are not coming out positive, you know.
Okay.
So far, thank you for having called the doctor, and you please tell me where these centers are. I go seek further medication for my problem. Right now I've been attending for around 3 months without stopping, and I don't know what the problem is. Please, if they can answer me, then tell me if I'm fertile or not. Thank you.
Thank you very much. We appreciate that. Right. Let's respond to the First Lady. We can respond to the First Lady. Tuberculosis. Yes.
Thank you so much. Tuberculosis is a very reproductive system, and the basic or the bottom line is when someone has missed to conceive, it is important that they get the right assessment. And the right assessment, meaning the tests, will guide into getting the right treatment. Because if you have tuberculosis of the tubes, of the fallopian tubes, and you get the wrong treatment, or you skip treatment, or you get undertreated, then it will not heal. Instead, it will spread. So the right treatment, tuberculosis of whatever part, should be handled with equal strength, because it can spread to other parts of the body.
Okay.
So and the fallopian tubes being delicate, they should be treated vigorously with the right medication. So the bottom line here is we encourage this lady to go to the right center, meaning they should see a gynecologist, and they should be treated fully, and then the fertility assessment will be done again. She has also asked, where are these centers? I will say where our center is, and Professor will say where other centers are. Our center is Nairobi IVF Center. It is opposite Nairobi Hospital, and we are on Agwin Kodek Road, Landmark Plaza.
Which branch of Nairobi Hospital, or opposite which?
It is not part of Nairobi Hospital. It's opposite Nairobi Hospital.
Okay.
Next to the dental school. That is how you describe. That is Landmark Plaza, and we are on first floors. That is, we are on Landmark Plaza, Agwin Kodek Road, and we are on first floor, and we call it Nairobi IVF Center.
Okay, then. Right. So, Professor, you can also respond to the second lady who called.
Yes, that's about bleeding. All right. Now,
yes.
Heavy bleeding can be either due to a problem of the ovaries, where the hormones come from, or a problem of the uterus. The uterus has two basic problems that result in heavy periods. The first, and the one that is very well known, is the uterine fibroids. The fibroids cause heavy bleeding and infertility. All right? And addressing that is usually to remove the fibroids, so that you can restore the normal structure or architecture of the uterus. It can be very big, and a bigger structure will bleed more. I think it's easier to get it that way. We have another very common condition that is not commonly diagnosed. It's adenomyosis, a change again of the muscle that reduces the uterus, makes the uterus not contract very well, because the way the uterus stops bleeding is by contracting. So adenomyosis is common. It's always a challenge, even in medicine. It's a challenge in treatment. And if you have adenomyosis, we usually tell people to give birth first, because you never know when it will be so bad that the uterus needs to get out.
Okay, but what about the meat residue she mentioned?
Yeah, that's right. So that is heavy bleeding. So what is happening is that the blood is so much that is held within the uterus, because the cervix is narrow. So when it is inside there, it clots. And then when it gets full, then it is pushed by a contraction, and it gets out as clots, and it will be interpreted as lumps, as meat-like, and so on and so forth. But these are clots. It's an indication that the bleeding is very, very, very heavy.
Right.
So the ovaries also can have problems with ovulation and difficulties, and therefore the hormones become disordered. What Mrs. Noreh has been calling hormonal imbalance, and one of the presentations is heavy periods. Also polycystic ovaries. Some varieties of polycystic ovary present with very heavy bleeding. So what are we saying? That you need to go to a specialist, obstetrician gynecologist, who can therefore be able to localize or identify the actual problem within this total number of possibilities, and then it can be addressed.
Right, and as we wind up, because we do need to wind up, maybe you can tell us where you can be found or where your center is, Professor?
Yes, well, I run a center called Nairobi Fertility Clinic. It is just opposite Nairobi Hospital in along the junction of Agnes Kodek Road and Roughbatch Road. It's a new building. It's been there for 3 years. Before then, I was practicing within Nairobi Hospital. The same thing.
Okay, then. Right, so any final comments on this matter, Dr. Anything you'd like to tell our viewers in terms of knowing their, productive health, knowing about themselves?
Yeah, as we wind up, I want to thank Merck for this program, for creating awareness to the public, and to thank the media generally for drumming it up. Okay. I want to thank all the participants like Mheshimiwa Joyce Lay and Professor Koigi. He has been up in it, and we congratulate you, Professor. I want to say this, IVF treatments or fertility treatments in Kenya, we need to take it a notch higher by enabling, or rather training, the clinical officers in the counties to be able to do the basics, so that the people, say in Busia, because they don't have many gynecologists, they are able to do the basic assessments, so that by the time the gynecologist, because I'm sure each county has at least one gynecologist, and one gynecologist cannot cover the whole county. So the people at the peripheral, at the health center levels, should be trained to be able to do basic and detailed assessments on infertility. Okay. And then by the time it reaches the gynecologist, it is something that is halfway done and progressing. And that will be easy for the clients, and or rather not clients really, for the patients. Yes. Yeah, the patients will be able to be met. Their needs will be able to be met individually.
Okay, then. Yeah. Right. So our final comments, Professor.
Yeah. Well, I think the University of Nairobi, the Department of Focus on Gyna, is organizing to have a fellowship training for specialists in obstetrics, in infertility. Okay. Now, I think we need to make sure that these services, at least at reasonable level, can be provided in the counties. The Director of Medical Services has also said his interest in the projects that would take IVF programs, all right, to the counties. Start with a few counties, take the service to the people. And Merck is also willing to provide some support through the social responsibility arm of the Merck Serrano. And I think we as a university are willing to partner with the government and with any sponsors who can make this service more accessible to the Kenyan public.
Okay, then. Right, so thank you so much for coming in today, and I wish you all the best. And of course, I believe we'll have you back to give us the progress on how the campaign is going. Once again, thank you so much for coming in today.
Thank you.
Right, so basically that's the information you need to have. All the questions that you've had, they've been able to, answer them right now. So keep sending them. I'm sure we'll be having them back, and they'll be able to answer any more questions that you may have concerning this matter of, infertility. On behalf of everyone who makes this show possible, do have yourselves a lovely day. Thank you for watching.